We are in the home stretch for the afternoon. We appreciate everyone's patience and diligence in sticking with us today. This afternoon's panel discussion is regarding real-world data and patient-reported outcomes, and how does RWD and patient-reported outcomes inform clinical practice. I will be moderating the session this afternoon. My name is Barmapov from Prism Public Affairs. To my left, we have Dr. Michelle Mezei. She's from the University of British Columbia. She's a neurologist from UBC. And then to Dr. Mezei's left is Sabrina Rebello from the Amyloidosis Research Consortium. So to begin today, if I may ask the two of you, for those who are unfamiliar, please share with us what your definition of RWE, real-world evidence, and patient-reported outcomes is.
Sure, so I'll jump right in. So when I think of real-world evidence, I think of it in contrast to clinical trial data. For clinical trial data, you have a very small subset of the actual patient population to try to ascertain whether or not a treatment is effective. It's not necessarily reflective of all of the patients out there with a particular condition. So to really simplify it, like because I'm an American, so if you just kind of based off like Real Housewives of New York, and you would think that's the experience of all housewives or wives in America, you would be, way off. So real-world data gives more of a glimpse into like the real world of the patient clinical experience that any clinician might see for, particularly with an amyloidosis patient. I don't know if you want to add anything to that.
Not really. I mean, I think what you guys have done is developed a number of tools focused towards HATTR. I know that we're using, though, patient-reported outcomes more and more, and I think it did come into place through clinical trials, I think, or maybe not, but that's how we as clinicians have started to see it used. You get it in various clinical trials, and luckily now the regulatory bodies and people evaluating the benefit of trials really want to see patient-reported outcomes, not just, some hard score medical outcome,
Right.
exactly what that means to quality of life or disability, how it affects the patient too.
Right.
And now how are we using that once it gets out there? That's really important. And now we're actually having to use some of these things just for funding, to obtain the funding for some of these treatments too.
Can you give any additional tangible examples of how real-world evidence or patient-reported outcomes are being used currently in amyloidosis research and care?
Yes, so as part of my introduction, so I'm from the Amyloidosis Research Consortium, so we're a patient-led organization that works with collaboration with industry, academics, as well as patients to really push forward patient outcomes in terms of access to treatment, accelerating treatments that are available. And one of the initiatives that we did was develop ATTR-specific patient-reported outcome that tried to encapsulate the whole experience of a patient with ATTR. So the symptoms, severity, and frequency, it's 31 different symptoms that any patient might experience in the past 4 weeks, as well as the individual impacts. So there's a physical component score, there's an emotional component score, as well as social and role, like how you're able to fulfill your role like in your society of friends, in your family, and at work, and also physical, emotional. Wow, brain freeze on a Saturday afternoon.
Social, was it social?
Yes,
work?
social, yeah. Thank you. Yeah. And so that's one way that we've, as an organization, tried to fill a gap where a lot of these clinical trials that are undergone and in clinical practice, there's not a ATTR amyloidosis specific measure. For most recent clinical trials, they've used the Kansas City cardiomyopathy score, as well as the Norfolk for folks with polyneuropathy. And while these have been good and applicable in those situations, they're not disease specific. And I think they're really missing some of the pieces that are unique to this specific disease. And it's important to understand who is the best to answer the question of the quality of life. It's from the patient themselves. So having that patient-reported outcome of what the impact of the disease is on their quality of life is an important component, not only in clinical practice, but trials and research in general.
And I think it's also helpful, I've noticed it's helpful to start using some of these, even though I'm still using just basically the Norfolk diabetic one. And then there was a disability, the rods and a compass for autonomic symptoms. But, you know, using these scales, whatever you're using, gives you some number. And I think I found that quite interesting and satisfying, and I think some of the patients have too, because, you know, I usually ask them, okay, how are you doing? I'm better, I'm worse, you know, it's very subjective, they're the same. But when you actually have a little bit of a number to follow over time, it can give a hint, because sometimes they feel worse, but it's actually the, you know, the objective stuff that I'm looking for is the same, but something's still going off, and that you have to try to sort that out.
Yeah, it's always nice to have something quantified and distilled down to like a particular number. So for like the SF-36, like you have your physical component score and your mental component score, and you're like, okay, I'm a 30 at this visit, and I was like a 40 at the other visit. Like, then you can kind of see how you're doing over time.
Yeah.
I think is an important, for patient perspective at least.
And maybe if it's breaking down some aspects, you can try to see what is, you know, exactly that is where the problem is.
Right.
See what you can do about that, yeah. And it kind of goes back to, I don't know where Noel is, but what he brought in about not liking to separate this disease into cardiomyopathy and neuropathy. And, you know, we've been following this, like if you're this scale that you've developed, you know, sort of merging all the symptoms together.
Right, yeah, so
That was really
the
important,
scale has, it's for wild type and hereditary, and also regardless of symptomology. And one of the things that we found is that even like wild type patients that are largely, you know, have cardiac involvement, they still have a pretty high neuropathy symptom score as well. It's obviously not as high as some of the hereditary folks, but that's an important component that you might miss if you're just looking specifically at the heart or just doing like the Kansas City cardiomyopathy score.
So how do you think the future of PROs and real-world evidence can help inform clinical practice moving forward?
Well, as a researcher, I think it's the only way that it can inform clinical practice. But I think like when patients get diagnosed or patients see their visit, like they want to know what it means and how it's going to impact their life. And the only way they can really know that is from looking at other studies, other papers that looked at patients that are similar to them and can tell them like, you know, now that tafamidis has been approved or what, like patients live this long typically and they might experience like these symptoms, and it just kind of like shows like what the road will be. And then moving forward, it gets a bit of a feedback loop for real world evidence as well as clinical trial data. Like you need that real world evidence to inform what that next clinical patient population might have to be. Because the patients that were in the ATTRACT trial are very different than what the patients are in the current trials, and that has been informed by what patients have been in the clinic and what has been reported for what the experience of the disease has been for the past couple of years.
So that sounds like health equity. Are you able to perhaps elaborate on a health equity perspective and how real-world evidence and patient-reported outcomes can help to inform various populations from a health equity perspective?
Well, from a recent study that was presented at ISA by myself, I did see that the disease burden for patients with V122I had much worse across all the components of the ATTR-QOL, the quality of life measure. So that's like one piece, and you might not necessarily see that in a clinical trial or anything else because it was such a small subset. Like we only had, I think, about 16 patients. But that can kind of inform like other targeted movements to try to help get to those patients quicker and like kind of frame the discussion of what might be the best management for those patients as well.
I mean, I actually thought that was really surprising to me because I always thought, okay, well, because I'm biased, I'm a neurologist, so I'm seeing the difficulties in quality of life and all the pain, you know, how that impacts it. And I was quite surprised to see that the one with the predominant cardiac had generally worse scores.
Right.
But it just shows, I guess, I'm not sure about equity, but in terms of certainly says what are you going to have to focus on. Mm-hmm. That's important to the patient. Those are the symptoms important to the patient.
And is that from a clinical practice perspective something that you see, that what is important to patients sometimes is different than what sort of clinical practice guidelines or clinical data demonstrates? Do you see that disparity?
Well, I mean, I guess I think if you're a good clinician, you're trying to listen to the patient anyway. So I don't know if you need always the scale or the score. You know, like I mean, if you have a patient who's able to communicate that to you, you know, this is what's bothering me. I'm going to go try to treat that. But I guess it is certainly still a helpful reminder. And sometimes, say, if I was just focusing on the exam or the nerve conduction studies, which frankly don't really always correlate or you know change. And yet their quality of life scale is going off, or they're bothered by fatigue. I'm not sure if that's part of, fatigue. Fatigue is a big one, you know, like where there's nothing that we can hard to scale sort of measure for fatigue. And, you know, your 6-minute walk test isn't always going to capture just fatigue, but it's a huge impact to quality of life, you know. So, I mean, knowing that might be that's what's important to the patient, then you look at what else can you do to help with the fatigue, not just trying to, you know, improve their neuropathy or their cardiomyopathy.
Now, how is this type of data being gathered and stored and then helping to further inform clinical practice?
Well, one way, so my organization does annual surveys, cross-sectional surveys of patients with amyloidosis. We call it the community survey that we do once a year. The ATTR-QOL specifically has been implemented in a couple of clinical settings as well as some clinical trials as well. And I think just having that, that tool or any tool that's measuring quality of life is important. And I know this isn't quite answering your question, but in terms of implementation, like it is relatively simple to just add in a couple of quick questions to the patient as part of their intake form, and that can help inform the clinical discussion. But in terms of actually gathering the data, I mean, right now, like a lot of centers are individually collecting their own data, and what measures they're using is kind of up to them. And I think that also kind of feeds into the previous discussion about the AI. Like those are the same data sets that would be included in developing those AI algorithms. But I mean, real world evidence can be gathered from any source, like claims data, insurance data, medical records, specific clinical information. Like I don't know if you have like a data set that you have for your patients, and then you're just kind of following it over time and seeing what trends you might see over the years. So there's really no limit based on your imagination of how you could probably gather these data.
But there's certainly, I mean, there's no uniform way we're doing it. We're kind of judging by you as a clinician what you're doing, or if you're sending it out and you have a group you're sending it out to. I've been led by, you know, sort of deciding with our funding agency in BC, you know, what scales they want to follow, but it's very different than what they require in Quebec, for example. I don't know what they require in Alberta or in Ontario. So, you know, kind of depends. Now, most of these funding agencies will take the feedback from the clinicians involved in the area, so you know, that helps. But so, for example, in Quebec, it's NIS, right? You guys are actually.
That's it, and we're trying actually to get it out if possible, because it seems to be a hurdle. So
Yeah.
we're trying to have our.
So it's the neuropathy impairment scale, right? So it's quantification of the exam.
Yes. So every jurisdiction, well, while there are many Canadian common mechanisms, Quebec may stand apart, and one of them is the NIS, Neurological Impairment Scale, which is a standardized physical exam that needs to meet certain criteria for drug reimbursement. So this is there are areas of influence we can try to move to have them budge, but it doesn't always work.
I'm curious, what do they, anybody here from Ontario, do you guys have standardized what you have to do?
So it sounds like based on what government agency or what health authority you're speaking with, the standardizations change, and that can change province to province. That can change whether it's regulatory, reimbursement, insurance companies, whatever. Is that lack of standardization a challenge when it comes to identifying which data to gather and what is necessary to meet the criteria for each agency, body, regulator, whoever it may be?
Well, I don't think it's really necessarily difficult. You get used to what, your area wants and you put it in. It would be difficult if you were doing it for research purposes, but this is very different, right?
Right, yeah. So from a research perspective, having different data points from different areas would make it very difficult to compare across different provinces, or even like from the US versus Canada, like it's comparing like apples and oranges. It would make it very hard to try to make a inference based on those data.
Are there any other challenges relating to this type of data that you encounter that you think is important to share?
I mean, it's the time it takes. In the real world, this is, where most of us are working fee for service. You don't have a nurse helping you. You don't necessarily have a secretary or an assistant who's sending the stuff out. Yeah. So that depends on, those are the resources that we don't have. But it's true. If you could give it out online, if there's motivation, it's potentially there. But I can see that as one limitation. And also, what do you do with the data?
Yeah, so it's, the physician, the researcher's time, the resources, like you need to have a database in order to collect this. You don't want it on like some pieces of paper thrown about your office, or like a Access database that just kind of morphs over the years. Like you need a designated like database that you would collect the data, clean the data, curate the data, and then as well as like the patient perspective. Like if they're being asked like the AT2RQOL promise, the Norfolk, the Kansas City, like that's going to take them like time each time they're going to the visit, and they might not have it. And also like they might not physically, like they might have trouble like reading it if it's on like a tablet or if it's online, or just like scrolling through it, and then you get like survey fatigue, and then you're not getting like good data. So it's both the time of the physician as well as the patient.
So is there a way then to build patient-reported outcome parameters in a way that is most patient-friendly?
I think taking a targeted approach for what is the most appropriate for your patient population, what is the, what gives you the data that you need to get reimbursed, to inform your clinical practice and to help the patient, as well as what would be like the most interesting research question might be kind of like in the back of the mind, but that's kind of like at the low end of what you would want to do to kind of tease out which ones you want to do. But I think just trying to find like the bare minimum of getting the information that you need to do your job, as well as what will help the community in the future with adding to kind of the body of evidence, the body of knowledge about that disease.
Are they using the scale, or the one that you developed now in some of the newer clinical trials?
They are, yes.
Yeah. Which ones are they using it in?
It's in the open label for eplontersen right now, and then I think that's all I can say.
I mean, the ideal thing would be simplifying it, because you'd be using one sort of main one that's designated to this disease. That would be very helpful. Yeah. Mm-hmm.
But then you have to get a bunch of people to agree that they're going to all use the same measure, which.
But I saw one of the papers you sent me that you actually were validating it against some of these other ones, like how it compared to Norfolk, how it compared to, right, in different aspects of it.
True. So the AT2RQOL does compare well and does track well with all of the other measures that are used in this disease. So what I would like in my organization would love that this could kind of take the place of all of those, and you just have like one kind of cohesive piece. But I understand that there's a lot of other factors that have to go into using some of these other ones for reimbursement, for regulatory. Like there's that history that's there. So you just can't just wipe the slate clean and just kind of use what's bright, new, and shiny right now.
Aside from informing clinical practice, are there other benefits in gathering and analyzing this type of data?
Well, kind of to tag on what I said before, like it helps inform patients like what they can expect. They can see like how they might compare to like other patients, and what they can expect moving forward. Like if they're just recently diagnosed, have had symptoms for only a few years, kind of relatively early in their disease course, they can kind of see how they compare to other ones, and that might alleviate some of the anxiety of like a new diagnosis, just kind of knowing what to expect on the road ahead.
And how do patients find this data?
They can come to the Amyloidosis Research Consortium website. We do have some of that data available on our website. And then, like, at least for the ATTR-QOL, like, we have a couple of publications that have either been presented at ISA specifically, and we're working more towards like the full manuscripts in coming weeks, months.
Now, if you were to blue sky what kind of data you would like to gather, both from a clinical perspective and just from a patient-reported outcome, a real-world evidence perspective, what would you like to see?
I would like to see like the quality of life data for like all patients, whether they're day one or, you know, several years in, and then what that data looks like over time. Like, this is a new measure, so we haven't seen any longitudinal data, but I just think being able to see the progression, like even for asymptomatic hereditary carriers, like maybe they have a certain baseline score, and then you can see like maybe there's a certain level where then it kind of triggers that they have active disease. That's kind of what I would like to see specifically for the ATTR-QOL. For other real-world evidence, I want more data. That's just me as a researcher. So the more the merrier. But I know that's not feasible.
And as a physician clinician,
Something simple.
Simple.
We should ask what about the patients? What about people here in the audience? Have you been asked to do any of these scales? Do you enjoy doing them? Do you find what do you find good or bad or valuable, not valuable from them? Anybody have any comments? Yeah.
Thank you. Yeah, I've completed these the standard forms repeatedly over the last 5 years through clinical trials and stuff. I found the information that was presented challenging to go through, to be brutally honest, and make sure that the data that I'm giving is accurate. But I get no feedback. I've never received 1 ounce of feedback from probably 30 plus, forms to fill out over the years. So it'd be kind of, from a patient's point of view, it's one-way street. I'm giving, the organization that's offering the questionnaires to me, but I'm not getting any feedback. All I can do is glean from the reports that come out from the clinical trial at some point near the end of what the overall aggregate averages are. And hopefully I'm in that mean somewhere, not an outlier. But it'd be kind of nice to, at some point, if you invest that kind of time over 3 to 5 years in clinical trials, to get a little feedback so that you have an understanding where you run in the pack with everybody else. And that kind of gives you a balance to say, yeah, that sort of correlates to the way I feel and how I've progressed through this trial. Opposed to the big question mark saying, okay, that's great, I've done that, but what does it really mean at the end of the day?
Yeah, and I know for some of the trials, I was involved with Apollo, and they did give the information, and I sat down with each patient at the end of the trial as the PI, and the ones, they found it quite valuable because they saw, this would have been the progression of your mNIS+7, or this is your Norfolk progression. Had you been on placebo, this is what the average did in the trial, this is where yours was. So that data should be there depending, I don't know what trial you were in, but depending on certain trials, they do sometimes give that out at the end.
Yeah, sometimes they give it out unless there's other mitigating circumstances, which, they have to hold on to that data. It could be years after the trial closes before that information.
Yeah.
And it's really, in the fine print, it's at their will to let you know where you were on the clinical trial, whether you're on a placebo arm or the drug arm.
Yeah.
And it's only, you left your own devices to figure that out.
Yeah.
And if you're astute enough, you can do that.
Yeah.
It's not 100%, but you can come pretty close to which arm you were on based on your own interpretation of your progression. I got worse during, things didn't change, I just have kept a progressive course during this clinical trial, or the other way, a light bulb comes on, so I feel great now. So, I mean, those, even that at a rudimentary level will let you know the potential of being on one arm or the other arm.
Yeah, it's nice to know. I know the ones that I went over with, they seem to appreciate it, yeah. It's good feedback.
Any additional thoughts or questions?
Important in the patient's journey with amyloidosis is also the caregivers. Has any research been done with caregivers or looking at a PROM that looks at caregivers?
Yeah, so there's the Zaret Burden Index, the ZBI. So we started putting that into our caregiver survey. We do a patient and caregiver survey, and so we recently did that starting last year. And so we are starting to see, like, based on patient organ involvement, like obviously caregivers are having more of a burden. So we completely recognize that that's a major issue, and we are trying to start looking at it. It's just kind of early for us, at least. But we are seeing, like, there is significant burden based off of, obviously, like, the relationship with the patient if you're a spouse or a child, like if you're caring for a parent, and then also, like, what the disease activity, obviously, if the patient is not doing well, it's going to be more of a burden. So we are starting to see that, and it is becoming more of a area of research within the community.
Other questions?
Can you
Oh, the mic's
tell
coming.
me what your, sorry, okay, there you go. You mentioned that you have a publication coming out from your organization. What is that telling us as a group of patients, and how is it, yeah, I guess, what is it going to tell us in terms of our progression, or what are we going to learn from it if we look it up on the site?
Yeah, so if you look, it's not going to tell you necessarily anything about your progression because it's just looking at one snapshot in time. But I think the particular study that I'm writing up right now, like, it was just what is the burden of ATTR in patients, like, at this time. And then, so what it will tell you is, like, you have, or not you particularly, but so wild type patients have, you know, quite a bit of cardiac symptoms, like, compared to some of the other hereditary types. You can kind of see, like, where, like, the V122I, like, have a higher burden than some of the other types, even though it was a much smaller population. So you can just kind of see, like, the relative burden of ATTR in the past 4 weeks for those particular patients. I think moving forward, like, once we do more of these studies, then you could sort of see the progression, and like, particularly with some of the clinical trial data that might be, or that should be coming out next year, is we could see, like, for patients that are on treatment, like, this is what how the quality of life would change for the better, hopefully, for that. So unfortunately, that's a bit off.
Or I guess what
For
my
2026.
patients sometimes look at the score, and they're quite reassured if the score is staying the same, or has it improved since they started treatment. Is it telling you anything different than you're already feeling? I'm not sure, because you know if you feel better or the same. But I guess sometimes some of my patients feel like they're worse, and we still can't figure it out from these scales, because the scales are better, you know. We looked at one or two recently who, unfortunately, after many years, and they were started treatment quite late, it was just, you know, he said he had to call it. There was a lot of things going on, and the quality of life was terrible. He went for MAID. And yet I'd been following the scales with Suzanne here, and it's surprising, I just looked back at them, and they hadn't been taking off and getting worse. So clearly, they're not capturing everything, right? You know, I believe his quality of life was terrible. The scales were otherwise relatively stable. Yes, things were slowly progressing, but the numbers didn't reflect it as bad as directly to that patient. So Is it going to help you always? No. But I think sometimes my patients have found it helpful to see that the numbers are stable or clearly much better than before. I've had some patients whose scales are now reporting 0 on their COMPASS score, so no autonomic, when at the beginning of their treatment, they had a significant, high score on that. So, but I guess that depends on how you would personally would feel if that would be helpful or not. I think it depends on the individual.
Just about, it also depends on the day.
True, it doesn't it? Yeah, exactly. Yeah, because
You sit down and do this, and it's a lousy day for you. You just generally suppress
yeah,
the numbers, right?
it's not just
But
all
if
your.
you're on a high that
Yeah.
day, you're really good. The numbers are high, so there's a fair amount of subjectivity.
And it's not all due to your TTR.
I'm sorry.
All the symptoms wouldn't necessarily be due to your TTR.
Well, they may not be.
May not be, yeah.
Influenced by. But
Yeah,
yes.
yeah. Good point.
Any other questions? Perfect. Thank you, Dr. Mezei. Thank you, Sabrina.
Thank you. Sabrina.